Good morning, everyone. Thank you for joining us for this morning's webinar, Understanding and Addressing the Complex Relationship Between Addictive Disorders and Anxiety. My name is Robert Hersey, and on behalf of the Florida Alcohol and Drug Abuse Association, I'd like to welcome you. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to the presenter and me, the host, FATA Webinars, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. An additional note for this morning's webinar, we will be using the raise hand feature, which is at the bottom of your screen. You should see an emoticon and a hand. When the presenter asks questions regarding the raise hand feature, you'll click that button. And after the question, you will click it again to turn it off. So please note that raise hand feature at the bottom of your screen. We will be using that a couple of times during today's webinar. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. One of these options is on the screen now, and all options are posted at the very top of the chat panel as well. After ensuring that your volume, both on your computer and speakers, if applicable, is not lowered, you may click the Communicate menu, then click the Audio Connection panel. Click Disconnect. Click on the Communicate menu and the Audio Connection panel again, and click Call in using computer, and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are on your screen and in the chat panel as well. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. We are unable to verify attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, please visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Please ensure that your name and email address match what you provided when you registered for today's webinar. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your certificate of attendance. Please note that the evaluation will close at the end of the day on Friday, November 22nd, 2023. Excuse me, that would be Wednesday, November 22nd, 2023. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing the survey, please fill out a contact form at www.fata.org or email training@floridabha.org before the evaluation closes. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. And now I would like to welcome our presenter today, Dr. Bruce Liese. Dr. Liese is a professor of family medicine, community health, and psychiatry at the University of Kansas Medical Center, and clinical director at the Coffin-Logan Center for Addiction Research and Treatment at the University of Kansas. He is a fellow in 3 American Psychological Association divisions, past president of APA Division 50, and an APA Council representative. He has taught more than 100 courses and workshops on addictions, psychotherapy, and evidence-based practice, and supervised hundreds of psychotherapy trainees. Dr. Liese has more than 75 publications. He is on the editorial boards of 3 APA journals, and he has co-authored 3 texts on addictions. Dr. Liese is a recipient of numerous awards from the APA for his service and contributions. In addition to these ongoing activities, Dr. Liese continues to see approximately 25 patients per week. And now I'd like to welcome our presenter, Dr. Bruce Liese. Dr. Liese, I will turn it over to you.
Thank you, Robert. Appreciate it. Good morning, everybody. I see that we have 162 people in this meeting this morning. I hope everybody sticks around, whether you're eating breakfast or washing the dishes or brushing your teeth. I hope you are able to stay involved and engaged throughout. I really have not had many opportunities to do workshops where I don't get to see any smiling faces. So I'll use my imagination. I love the fact that so many people said good morning. So to reciprocate, I did say good morning in the chat, but let's see, just randomly, Jennifer, Jean, Debbie, Jeffrey, Aaron, Beverly, Anna, everybody else, Dana, good morning. Glad you're here. Glad I'm here. It's I was just in Florida a few days ago, and right now I am here in Kansas, which is where I am, which I call home. So I really would like to make this a personal and valuable experience for all of you. So I'm going to do my best to keep us engaged, even though we don't see each other's lovely faces. Why don't we start? I made sure I knew about the hand raising signal in WebEx. It's on the bottom in the little margin there. You'll see a little, if you scroll over it, it says raise hand if you're on a computer. I'm not sure how it would work out on a phone, but please raise your hand if you're glad it's Friday and that the weekend is just minutes away, technically. Let's see if I can see some hand raising. I see one. I want to see if I can see hands. Do I get to see them, Eric? I don't see them here on the on my screen. Do I have to do anything fancy? Oh, I see hands.
They're in the chat.
In the chat. I'm looking in the chat and, well, I don't see any hands in my chat and I don't really see them on the right-hand side. So I may have to, I see a lot of them there on the left, right in the middle of my screen. Wonderful. Right. And when you lower, look at all those hands. So we are all in agreement that it's the TGIF. Wonderful. I'm going to take my hand down. You just click on it again. Yeah, I think I got about 170 thumbs up waves, or hands up. Horns, flames, great. So it's a good participatory audience. I won't be asking for hands up much more because what happens is it just scrolls through my screen and I can't really do anything but see them. I can't count them. So we'll have to use our imagination. As was noted in the introduction, I am a professor and I am a clinical director. But the most important thing I do, at least from my perspective, is see patients. I do see about 25 a week. I've been doing this for 40 years. This week I saw 30. Some weeks I'll only see 20, 15. But on average, it's absolutely no less than 20 and typically around 25. So I base a lot of what I'm about to talk to you about on 40 years times 50 weeks. I think it comes out to about 40,000 patient hours. And my patients are my teachers. So I really am passionate about research. So I do definitely conduct research and publish. And most recently wrote a book with Dr. Aaron T. Beck on addictions and the treatment of addictions, published by Guilford. So that came out last year, and all of these activities together make me excited about presenting the materials I have. I'm going to do my best to achieve these learning objectives for you, but I'm going to go through them quickly because what I'd like to do even more is to possibly do some role playing if we have time at the end. So I would like you by the end of this to be able to describe the complex relationship between addictive disorders and anxiety. I would like to be able to at least present case conceptualization as a process well enough that you can explain it. And I'd like to present at least one structured intervention for helping people with addictive disorders and anxiety. So let's start with so I'm going to try to do this first stuff quickly, though I don't want to go through it so quickly that it's superficial. I started 40 years ago. About 30 years ago, we did our first textbook on addictive disorders, and we were naive as you could possibly imagine. Back then, it was the cocaine epidemic. There really weren't any scholarly textbooks on addictive disorders. We were still labeling people drug addicts and alcoholics, and there were stereotypes, and people still pictured people under bridges, poor and keeping themselves warm with campfires and just begging. I mean, we just didn't understand addictions back then. Again, 30 years ago, we were in DSM-4, and of interest, we had this idea that some addictions were worse than others, and that is just not even measurable. If you used heroin, boy, you were the worst of the worst. And again, this was 30 years ago. I'm going to talk shortly, obviously, about the difference between then and now. So the sole aim of treatment back there was abstinence. If you didn't abstain, you were still, again, as I said earlier, a drug addict or an alcoholic. And we focused on relapse prevention, meaning don't do it again after you quit. Today, those of us who really study and work primarily in the field of addictions really know better. Not that it's relevant to a deeper wisdom base, but the opioid epidemic is what's predominant now rather than crack cocaine. Alcohol and nicotine use, though, continues to cause among the most deaths in the United States. And of real importance is the fact that you can get cannabis in most states. You can get weed or gummies or whatever in most states legally, and we still don't know what kind of tidal wave that's going to create. We are absolutely more aware of stigmatizing behaviors and language, though as you know and I know, we can't promise that clinicians don't stigmatize people who use substances and certain behaviors in an addictive way. So we meaning those of us who really love what we do when we work with people with addictions, do our best to not stigmatize people. The stereotypes just don't fly. DSM-5 is different from DSM-4. We can now include craving as part of addiction. Legal problems were removed because people who are minoritized and more likely to get thrown in jail for possession and use of substances, people who are minoritized, people of color, people who look different from the status quo, they're more likely to suffer legal consequences. So that's been pulled. So these are some really big differences. Of particular interest to me is behavioral addictions are recognized, gambling, gaming, and in the near future, even more. And most definitely the fact that addictions are looked at on mild, moderate, and severe scales rather than yes or no. So there's absolutely more to treatment than just trying to get people to quit and stop. There's also trying to prevent. There's also most clinicians worth their salt also pay attention to the harm caused by substances. And when people reduce their use, or they don't drive drunk, or they don't shoot up with dirty needles, that's considered a win in today's addiction treatment world. And this is all background, knowing that a big part of what we're going to talk about today is anxiety. But I just wanted to form this base and put the treatment of addictions and the understanding of addictions in perspective. People who have addictions, who come for care, should be determining their own goals. We shouldn't tell them what they should be doing. And as you know, motivational interviewing is a big, big, big deal in the treatment of addictions. So here's something that may be new for you. I don't know if it is, but it's one of the things that I consider most valuable. And actually, it was published by Mark Griffiths, who resides in Europe, in the Journal of Substance Use, all the way back in 2005, before even DSM-5 came out. So I really want to highlight what the core components of addiction are. I'm going to talk about DSM in a moment. Addictions exist only when they are salient, when they become important to a person, when they start to dominate the way they think and feel and act. And there are only 6 of these. So it's really valuable to know. And maybe now I'll start pulling in the component of anxiety. You know, when something becomes really salient or important to you, like using drugs or food or gambling or pornography or methamphetamine, when it becomes important or it starts to dominate, life becomes more difficult. And what happens? Anxiety goes up. So the salience of addictive disorders is an important one of the 6 components. Mood modification. Nobody gets addicted to something that doesn't affect how you feel. Put the other way, people get addicted because the addictive behavior or substance helps them feel differently. And what do you expect me to say, which I'll say now? It is, for many people, a way of managing emotional states exactly like anxiety. So addictive behaviors induces this desired state, like relief from discomfort. And what kind of discomfort are we talking about today? The discomfort you know to be anxiety. It doesn't really start with, I'm going to use so my anxiety goes away. When you're 16 years old and your friends say, let's smoke a joint, whether it's because you're smoking the joint or you're with your friends and everybody's together, it also increases, initially at least, the pleasant feelings and excitement or calm that you would expect from a psychoactive drug. So again, because this is a discussion about addiction and anxiety, the addiction becomes important. The use of the substance or behavior impacts feelings. And once you start using something over and over again to feel differently, it's kind of anxiety provoking to think of any other way. Tolerance is where more and more is needed for the same effect. That's something that we all know, people who treat addictions. So those are the first 3. The next 3 are withdrawal, and a lot of anxiety associated with the use of drugs is in the fact that who doesn't know that when you stop, there is a real discomfort. It's like, where is my habit? Where are my cigarettes? Where is the Where is the pizza, the brownies, the dessert, the pornography, whatever the addiction is, the withdrawal process. Now I'm sneaking ahead. I really have a bunch of slides on anxiety, but I want to make sure that while I talk about addiction, I'm also reminding you and me that this is all about addiction and anxiety. And it is a complex relationship. The question of which came first, the chicken or the egg, is never really addressed. So number 5 of the core components of addiction is conflict. And by conflict, I don't mean you fight with your partner or you fight with your kids or you fight with neighbors necessarily. It's also the impairment or the internal conflict that occurs when a person realizes that they have some serious dependency on something that's only harmful to them. So the conflict is much of the time, if not most or all of the time, anxiety provoking. And then relapse, when somebody quits, they may feel like they've got it all under control for the first day, week, or month, or some people only start to feel that after a day, a week, or a month. But, the whole idea of relapse, the anticipation I may relapse, what am I going to do when I go to that party? What am I going to do when I go to that event? What am I going to do when I see my family? Just the thought of relapse can generate anxiety in people in recovery. So for those of you who crack open DSM, this is the cannabis page, the criteria for cannabis. And what I've done is paired up on the right-hand side those 6 components. So like number 1 for cannabis, if you look at DSM, is tolerance. And number 2 is efforts to quit. And number 3 is a lot of time spent. Well, those are from the 6 components I talked about: tolerance, conflict, and salience. The difference is that Griffith's criteria are simpler to remember. There are 6. They absolutely, fully, 100% overlap with addictions in DSM. It's really much easier. The more education people have about their addiction, the more likely it is that they will feel like as they gain understanding of their addiction, they may also develop a little bit more confidence in tackling it. And most certainly, if that occurs, there's going to be a decrease in anxiety about change. So there are the criteria on the left in black. There are the 6 components on the right. Just for the heck of it, I also put gambling up there. That's the first behavioral disorder that you get in DSM-5. Perhaps in a future DSM, we'll have gaming move from in the perhaps section of DSM to the definitely. But you see again, tolerance, withdrawal, relapse, salience, mood modification. These are the components of addiction on the right. And who wouldn't be anxious if they walked the streets, they went to work, they engaged with family and friends, knowing that they had developed a tolerance for a drug or a behavior they were using, that they were going to withdraw uncomfortably when they stopped, etc. So there you have my teeny weeny itty bitty little overview of addictions. Now I'm going to give you a little itty bitty teeny weeny overview of just fear, anxiety, PTSD, and anxiety disorders. Now, you notice that this talk is not about anxiety disorders. It's the complex relationship between anxiety and addictive behaviors, addictive disorders, or addictions, or substance use disorders, all of those. So I list here fear, anxiety, and PTSD, and I distinguish them. PTSD used to be considered an anxiety disorder because there is so much anxious pain associated with past trauma. And what do many drugs do with pain? They don't get rid of the pain, but what they do is they distract people from the pain. And for people with prominent fears, prominent anxiety, PTSD, boy, that sure is a tempting friend, in air quotes, friend. So what's the difference? Fear is an emotional reaction to an actual where you're watching it about to happen, or an imagined imminent, which is really kind of a real threat. I knew I was going to be presenting to you today. I was in California 2 days ago. Literally, this is true. At 5:30 at night, I was supposed to take the red eye back and get ready yesterday, and I was going to be all refreshed for today. And then what happened? We had a storm. The lightning was hitting the runways at the San Diego airport, literally hitting the runways. And I wasn't fearful of flying because they canceled my flight. What I was fearful of is that it would really interfere with my ability to be with all 190 of you. So fear is when the threat is imminent. Some people say real. Anxiety is when it's an imagined threat, when it is imagined without evidence, without really good, strong evidence, like the fear of going to an event thinking you're going to make a fool of yourself with absolutely no evidence that you're going to make a fool of yourself. Well, actually, the next slide breaks down the specific disorders. And again, today's presentation isn't about the disorders. Just looking at the disorders does the whole workshop a disservice because, well, I'll tell you why in a minute. You know what specific phobias are. They involve a fear or anxiety or avoidance of very specific situations. My experience in treatment is that in a massive, perhaps majority of anxiety that people talk about when they've been using their whole lives has to do with, a lot of the anxiety has to do with, relationships, social experiences. I run a regular community-based free recovery group on Wednesday nights. And one of the participants brought up the topic this past Wednesday. How do I deal with all these people who are going to look at me differently when I quit using? And that's not the disorder of social anxiety, but it is anxiety about how will I relate to people? Because what happens when you use extensively is that your personality is different from what it would be. And then when you stop, your personality is different. So, of course, there's going to be anxiety. A lot of people use drugs to manage panic, surges of intense fear. And for many people who didn't even have a panic disorder, when they quit using, they feel surges of, I don't know if I can do this. And that contributes a lot to relapse. Agoraphobia is, fear relating to crowds. General anxiety is another big one. I see a lot of people who are just fearful, anxious people, and they engage in substance use. They are afraid of new situations. Think about it. When you start using at a very young age, it's not unrealistic to think that you're not going to develop a lot of the social skills that come from adversity. And when you deal with adversity in life and you succeed at overcoming it, you have confidence. When you don't, you have anxiety. And then there is in DSM substance or medication-induced anxiety disorder due to use or withdrawal. I looked at the research on this, and it's pretty uncommon that you get an anxiety disorder because you stopped using. You'll be anxious, but it doesn't turn into some lifelong disorder. So here are some numbers. I think it's always appropriate to give you, and these numbers tell a very interesting story. And we're talking still about disorders. Again, this talk today is about anxiety generally. To look at just disorders, I think it would do a terrible injustice to the whole topic. So about 11%, and that's an average of all the studies, of adults have anxiety disorders. That's all of them. It's about 28 million people. Between 9 and 10% have a substance use disorder. So that's pretty darn close in numbers. That's around 23 million. This was older research, so I went to the current population statistics and I adjusted accordingly. So we had those million numbers right. So 9% of adults in the United States have an alcohol use disorder. And remember, They're measured now mild, moderate, and severe. It's not a yes, no thing. And only, I say only because alcohol and tobacco use is still, and and nicotine use is still much, much, much higher. About 2% have other substance use disorders other than alcohol use disorder. So, so there you have the substance use disorder and the anxiety statistics. Well, let's see. We don't, oh no, about 18%. Okay. And you see those numbers really jump when you look at people with substance use disorders. So it almost doubles that people with substance use disorders have at least one anxiety disorder. And it jumps precipitously that people with anxiety disorders use substances, probably to self-medicate. But the last line is important here. Comorbidity, having them together, is associated with greater severity and poorer outcomes when people go to treatment. That's why I'm here to talk about the relationship between anxiety and the disorders. But again, you can look at this slide. Very interesting. 11%, 9 to 10, 9%, 2%, 8. You know, my experience in treating people is that it's not the disorders that we have to worry about in treatment. How do people feel when they start to use? How do they feel when they take their first hit? When drinking is new to them? Suddenly, discomfort for many, many people goes away. And what happens if that's the strategy for many, many years? I'll drink and go to the party, or I'll go to the party and I'll drink and I'll be okay. If I smoke a joint, I have so many people with cannabis being legal now who use gummies to go to sleep or smoke, take a couple hits off a joint. So again, the point here in holding this slide for a few extra moments is that I'm not even that interested in the relationship between anxiety disorders and substance use. I thought about how I was going to say this, and I've decided I'm going to say that I don't think I've ever met anyone in treatment for addictions that didn't have coexisting anxiety. The complex relationship that I talk about in the title is really our people, many, many people, and I'll get to this in a moment, many people use to feel better, and a lot of people feel anxious because they have an addiction and they know it. There are so many different ways to understand the psychology of anxiety and that help us to understand why it's so linked to substance use. People with anxiety they're not overly, they're just overstimulated by the threat of whatever they fear. I sure as heck, when I was on a hike recently and somebody on the trail that I'd never been on said, "Careful, there are snakes ahead. So just don't veer off the trail." And I had I think probably optimum level of threat because I don't want to be dead. So the overstimulation of threat would be if I had said, "Oh my God, that's terrible. I'm going home." If I had a phobia to snakes, but people hike that trail all the time, the snakes don't bother people unless they go off on in the brush on the side. But the overestimation that causes people to engage in the next one, unnecessary or extensive safety behaviors. For a lot of people, safety behaviors involve going to their substance. People with anxiety often have trouble tolerating uncertainty. Not everyone, not just people with disorders. The thing to do with this list is to just think to yourself, when I have anxiety, I engage in a healthy amount of safety behaviors. When I have anxiety, maybe I engage in too many safety behaviors. Maybe I engage in safety behaviors that cause me more harm than the threat itself. So this list is something that would take me a week to go through in detail. There is a book by Abramowitz and Blakely, you can see at the bottom there. And every one of these psychological processes has a chapter in it. Worry and rumination, of course, is part of anxiety. For a lot of people, it's perfectionism. And it's interesting, one of the processes that occurs with addiction is people who try to quit, if they don't get it perfect, they go back to using. So I smoked one cigarette, I'm going to just go back to smoking. My recovery wasn't perfect. Or I went out with friends, I was abstinent for 6 months, I drank a beer, I've ruined my sobriety, I'm going to start drinking again. So the most interesting and important item on this list of 12 different processes randomly chosen from Abramowitz's book. And it's not a book for clinicians. It's just kind of a book that talks about these processes. I'm not going to ask you to chime in because you can't, but guess which one of these is the one that's most important. I'll give you a moment. Look at the list. Actually, the most important is the one on the lower left-hand side, experiential avoidance. When used carelessly, behaviors in response to feelings of anxiety, the behaviors are an effort to avoid the experience in a raw, untreated fashion. Thank you, Sheila. I did see your little heart. That was wonderful. I appreciate it. Anyone who wants to throw any of those up there, even if it's a thumbs down, I'll know to correct myself. Avoiding the experience is so much what an addiction is. And my understanding is I may be giving a workshop here in a couple of weeks on all of the disorders. And it's not going to be too much different. It just won't focus intently on anxiety. But experiential avoidance is what substances provide. I'm not going to talk about cognitive behavioral therapy at length, but ACT therapy, acceptance and commitment therapy, which is like an entire approach to psychotherapy and cognitive behavioral therapy. Acceptance and commitment therapy is like one giant handbook for how to live the serenity prayer. Having the knowing when to avoid something that's problematic and knowing when to tackle it because you can do it is really, and because you can make a difference is really important. So anyway, these are psychological processes underlying anxiety. And if you look at all of them, like attention bias is when you are really overly focused on what's going to harm you, like attention bias. Oh my God, I have a social event at Christmas. I don't know how I'm going to get through it. It keeps coming into my head. I can't stop thinking about it. I'm afraid of seeing my cousin. I'm afraid of making a fool of myself. What am I going to do? Oh, I'll pace myself and start drinking again just for that event. So the theories of what relates these substance use and anxiety, the three main pathways that you could imagine, and this is according to National Institutes of Health in 2020, the common comorbidities with substance use disorders. All three theories are good. Three good theories, three main pathways. Risk factors, early childhood development, insecurity, low self-esteem, trauma, depression, existing depression, those can indeed all contribute to both mental illness and substance use. So that's one pathway that's a legitimate way to understand anxiety. And if indeed, as I think I will be doing, if I do present on comorbidity in general, it really is the same thing. I mean, if you grew up in a very threatening home where there's little validation and you have to walk on eggshells, that risk factor is going to lead to both a trauma-like or related disorder and potentially substance use. And you notice I really don't have anything written up here about genetics, but it is one of the common risk factors. If you have a family history of addiction or anxiety, you are at higher risk, period. Mental illnesses can contribute to substance use, but substance use can also contribute greatly to addiction, chicken and the egg. But the word potentiate is a really important one. So keep that in mind as you help people with addictions. If you have an addiction, you and you use a substance, if you have a substance addiction or a behavioral addiction, and you use it to treat your anxiety or your depression or your insecurity, it's going to make it worse. Eventually, the use itself will, when you wake up in the morning and you think, I can't even go to work without taking a hit off a joint, that's pretty darn threatening. I can't even go to work without, oh, and guess what? My partner took all my weed and hid it from me because they want me to quit using, and I still have to go to work today. So each potentiates, each exponentiates the other. When you start using an addictive behavior heavily, it causes you to feel a little scared about who you've become. And as you become a little more scared about who you've become, you want to use a little more to stop feeling a little scared. So we're doing really well on time. What I'd like to do is have you consider, of the 100, and this has never, ever, ever, ever failed, out of 197 people, I know there's a chance that I can get some people to role play. And our good friend Eric Nelson, who's our technical guy, says he will bring you into the panel if you're willing to role play. We may or may not have time for it. It certainly would be reasonable. That's where I put myself out on the line and actually demonstrate some of the things that I do with people. But let's see if you volunteer, any one of you, or if I have enough time. I lost 10 minutes at the beginning with that wonderful introduction of me, so by our sponsors. But let's get going, and I'll stop chattering. When you provide treatment to somebody who's got a mental health problem, and my guess is that there are, up to 200 participants, my guess is that 90% of you provide some kind of care to people who are suffering, whether it's primarily from other mental health disorders or addictive disorders. When you provide that care, you are engaging in an activity where you talk about content. I'm lonely. I'm single. I can't find a partner. I'm addicted. I have a history of depression. I was mistreated as a child. I never finished college. This is all content. And all my friends are doing better than me. And this is all content. What are my symptoms? I have an addiction. My symptoms are craving and withdrawal and tolerance, and I relapse. Those are the six, by the way, I'm pointing out some of the 6 components of addictions. That's the content. But what's kept me, I'm 67 years old. What's kept me in this field for all these years? It's really the process, how change is facilitated, which is why I am willing to get up on a Friday morning and move my other appointments aside to get to talk to 299 people about addictions. It's not the content that intrigues me, it's the process. How you and I relate to each other in that therapy room or in that therapy group or in that agency where I encounter you. So how change is facilitated is an interpersonal process that activates intrapersonal dynamics. It's, hey, by the way, those of you who are giving me nice signs and signals, believe me, they're hitting the spot, and I am very grateful to you because I don't get to see any smiles or anything. So thank you, thank you. But the process is what's most interesting. When somebody comes to you at the various stages of readiness to change, a process occurs that is so important. People don't feel safe initially with a stranger talking about their vulnerability. People don't feel secure. People don't know that you're going to help them. People don't know that you have ever experienced what they've experienced. And that's all essential for your knowledge of how to proceed. So like I said, content is what's to be changed. Behaviors, emotions, decision-making skills. This is all content. So when we talk about anxiety and addictions, I promise you, you have my word. You have my word that when people come to you with an addictive disorder, they need emotion regulation skills. Like my old friend used to say, a dog don't drop a bone for no bone at all. If people are using, remember the 6 components of any kind of counseling or psychotherapy include mood regulation. The use of an addictive behavior is primarily to help somebody feel something. It could be just having them feel less craving. So you always want to attend to emotions as people as part of the process, but also part of the content. And people don't just quit using if you don't help them understand how they're going to manage their emotions as the abstinent or lower use. They claim they can use recreationally. Well, they're going to have a lot of anxiety as they see that that's a monumental task, maybe one that they're not even genetically wired to achieve successfully. People, when they've used long enough, they have problems with decision making and problem solving, and certainly self compassion when they're really miserable because they hate themselves because they can't seem to quit using and they're not like quote end quote normal people in their mind. So this is all content, judgments, interpersonal skills, communication skills, mindfulness, and then of course the category other. So that's content. So how the heck is change facilitated when somebody comes to you with an addiction? And you know, especially from experience, and this particular workshop, this 2-hour webinar, how do you facilitate change? Well, there are 5 components, just like there are 6 components of addiction. And this stuff, I'm not going to be an advertisement for my book on addictions, but if you want to know more about any of this stuff, the whole book revolves around this process. When you help people who are suffering in a clinical role, you always have to have a certain degree of structure. You don't meet them at the state park at some time on Friday and maybe camp there with them and leave sometime on Monday. You don't say, hey, it's a beautiful day, let's go play volleyball together. Similarly, you shouldn't sit in a room and instead of having a good structured session, enable people or encourage people to just talk about anything and everything all over the place. People who have problems with addiction serious problems are going to have some problems with staying focused and structured. Now, I'm not talking about somebody necessarily who wants to quit smoking, half a pack of cigarettes a day, which is treating someone with an addiction. I'm talking about people who have damaged like their prefrontal cortex, and it's very hard for them to stay focused. But structure is vital. You meet within 4 walls, and you sit in 2 chairs, and you face each other, and you try to use an hour effectively. That's all structure. Collaboration and the alliance, vital. And what does collaboration mean? It means you have similar or the same goals. Now, you and I can admit when somebody comes in and they have a lifelong history and a super, super heavy family history of addictions, and they want to use recreationally, in your head, the goal is to stop using. Everyone in your family has had this problem. You drink and drive, you shoot up, and you have your veins are shot, and you want to still use a little. But collaboration is the ability to identify goals that you can share, even if they're harm reduction goals. And that's how you form alliances with people who are not yet ready to change. Here's the deal. I look back on my first years, my embarrassing years of helping people with addictions 30 years ago. And the mode then was you can persuade them to quit completely if you use the right skills. You can get them to do what you want them to do. It ain't true, and we all know it ain't true. Case conceptualization, which I'm going to spend a whole bunch of time with. It's one of the objectives of this webinar. Case conceptualization is really, really, really learning about people you're helping. And when you learn about them, and I don't mean learn their cat's name, their grandmother's name, that they're building a, a house in the woods. I'm not talking about knowing everything about them. I'm talking about really, you'll see in a moment, really putting together a solid sense of what are the causes, what are the consequences, and what are the avenues for potential change, and what are the barriers and those things that make it very painful for somebody to live and then to change the way they're living their lives with addictions. That's all case conceptualization. Psychoeducation, everyone in therapy better be learning something. That's why that's among the many. Let's just take 12-step groups, which I am very, very glad exist in the world. I do not have a history of addictions. I do this work because it's, to me, the most important and fascinating work in psychology. But I go to AA meetings to learn, and AA meetings are structured. They're extremely collaborative. People are very supportive. AA, NA, all 12-step. When people talk about themselves, they describe who they are, and people get to conceptualize them. The 12 steps, the big book, all of that involves psychoeducation. And the 12 steps are standardized techniques. Making amends is a technique. You go to people you've harmed. So all good help involves a process that includes these 5 components. Keeping that in mind, and keeping in mind that, if you believe me, all change produces anxiety. Even good changes produce some anxiety. Attentiveness to that, structuring and collaborating and conceptualizing and even educating patients or clients accordingly, and even the techniques should be with an eye to how much anxiety does the person have about making changes. And talking about goals, they vary greatly across clients or patients or whatever you call them. So some people really come in to quit, abstain. Some people really just want to reduce the harm. Again, I run a group in the community that's 100% free. It's hybrid. We get 15 to 20 people from all over the United States, and at least once a month, people from around the world who come to it. Any one of the 200 of us here in this meeting, in this webinar, can attend it. All you'd have to do is go to smartrecovery.org and look at Wednesday night in Lawrence, Kansas, and you'd find my name for a group that starts at 5:30 Kansas City time, 5 o'clock p.m. and ends at 6:30. Some people, we get 30 people online, 20 people online, between 10 and 20 always, and we get between 10 and 20 people in the library where this group takes place. And I promise you, there are always new people in the group that say, well, I just want to reduce the harm. I don't want to drive, I won't drive drunk anymore. I'll only use on weekends. And, if that's what their goal is, that's what it is. We don't get to control anyone else's life. And so, some people really come for abstinence. They say, well, some people come because they're court ordered. And if they don't abstain, they're going to lose everything on the court's order. So some people just want to control other habits. Some people come to addiction treatment and they want to stop acting aggressively, or at least they know they better. Some people only want to feel better. And if you can provide that for a while, you'll notice that they may come over to, well, I'd also like to change my addictive behaviors. Again, people will come to treatment because they have anxiety. Anxiety is more of a motivator than depression because it's a buzz. It's not a good buzz, but it's like you can feel the blood pumping through your veins when you start to get palpitations from anxiety, and you just want something to feel better. And for some people, thankfully, a 12-step group or smart recovery or psychotherapy or group therapy, all those things enable people to feel better, even when they're not ready to change their addictive behavior. Some people want to learn how to get along better with people. Some want to cope better. So again, these diverse goals beg the question, how do you define recovery? If you define recovery as how many days since you last used, and that's all you think about, you start missing what some people call a little bit of stigma, but I'm just using the term dry drunk, So recovery is making positive changes in many of the areas I have up on the screen. It's just that when people come to get help from you, they may not know that after 5 months of seeing you, they're also working on a bunch of these other things. So as you keep that in mind, remember, anxiety probably driving them there. Anxiety about losing everything because the judge ordered it. Anxiety because they've tried to quit a million times and they haven't been able to. Anxiety because they are doing it because they're threatened by divorce or a breakup. So now let's hop over to case conceptualization. Remember, case conceptualization, it's dead smack in the middle of my list because I think of my list in my crazy little imagination as being like a mountain where structure and standard techniques are at the bottom. As you climb the mountain and get to the top, the center, the peak, it's case conceptualization. You are in your office and or in your agency or in the school you work in or whatever, or at home like me doing remote work. And you're trying to help somebody who's suffering, who's got anxiety, who's got an addictive disorder. The anxiety they don't think they can live without, or they don't think they can live without their partner who's going to leave them if they don't quit. So it's the collection and integration of clinically relevant information as an iterative process. What does iterative mean? It means it's ongoing and it never stops, and it adds to, it gets added to, it gets subtracted from. You learn more, you pull some stuff out that you didn't prove to be true. It's the identification of problems and change targets. And it, like I said, doesn't stop. It's hypothesis formulating and testing. A very simple hypothesis. Hi, Joe. What are you here for? Well, my wife says I need to quit drinking. Well, I have a hypothesis that you may have a drinking problem, but I want to test that with you. Do you think you have a drinking problem? Well, no, I think her dad was an alcoholic, and I think she's just scared because I only drink a 6-pack a night. Oh, okay, you only drink a 6-pack a night. Well, again, I never say this, but I start to hypothesize, you do have an alcohol problem, but I'm going to test that by asking you, a 6-pack, gee, what do you think about that? And what would happen if you didn't have that 6-pack? And did it start as a 6-pack? And notice I'm going through the symptoms and I'm hypothesis testing. And when he says I'm down to just 2 beers a night, 5 days a week, do I review my hypothesis that he has a drinking problem and say, well, no more. You're drinking 2 beers a night and only 5 days a week, so you must not. So that's the process. And your model, your theoretical model, how you view it, whether it's through the lens of 12-step, lens of cognitive behavioral therapy, that's going to influence your conceptualization. But everything you do should depend on how you conceptualize people, and you should pay exquisite attention to it and be organized in doing it. How are you going to be organized? Well, pay attention to what people say. Content and process again. Pay attention to what people are saying, cognitive, because that tells you what they're thinking, right? Case conceptualization requires attention to cognitive, content, and process. Pay attention to what they're saying, because that's how you know what they're thinking, and that's how you know what they might do. And pay attention to how they think. Do they focus well? Are they psychologically minded? Are they mindful? Are they cognitively flexible? Do they inhibit impulses that are dangerous to them? These are all questions in your case conceptualization. And if you happen to be well versed in cognitive behavioral therapy, here's an example of how you would think about it. You know, I put this as cognitive behavioral model. This is the stuff from our book on cognitive behavioral therapy for addictive disorders. Um, uh, you know, I claim it's a cognitive behavioral therapy model, but it's pretty darn universal, regardless of your theoretical religion, what you believe, whether it's in a more spiritually oriented approach to recovery, a more intellectually based approach, a more emotionally based approach, psychologically, if you think, you know, you have to deal with underlying processes. There's pretty strong agreement that external triggers are vital, upper left-hand square. And if it from the very start of NAAA 12-step recovery, thoughts and beliefs were thought to be activated when you were exposed to triggers. They call them stinking thinking. So because we're talking about anxiety today, the thought's probably going to be when you think you have to go to an event where you'll be make a fool of yourself. I can't stand to feel this anxiety. And then the third box over on the right, on top, that's where the urges and cravings come from. It's like, I need my thing. I need my addictive behavior to bring down this terrible anxiety. And the opportunity to abstain, the ambivalence, yes, no, I'm going to do it. No, I'm not going to do it. I quit. It's been 6 weeks. It's been 3 weeks. I promised I wouldn't use again. That ambivalence itself is anxiety provoking. And then giving yourself permission because you think you can't stand the anxiety. Boy, that's where the lapse and relapse occur. Now, this doesn't occur in a vacuum. These thoughts and beliefs and actions related to addiction develop over time. And your early life experiences, including your genetics before you pop out of the womb, early life experiences distally in the distance, even before you were born, like I said, genetic, but then psychosocial and environmental, they all are risk factors that contribute to your vulnerability. If you grew up in a threatening home, if you spoiler alert, if I do the next workshop, we're going to be going through some of this stuff again, but I'll be talking about things other than anxiety, because it's my belief that our understanding, yours and mine, our understanding of addictive behaviors developmentally and currently is vital to being effective at what we do to help people. I don't know if we're going to get to role play. We're an hour in, and there's still a whole bunch to do, but hopefully this is sufficiently engaging that you can live without us role playing. We'll just see. There's a lot of content, and I think it's well worth it. So how do these early life experiences cause people to develop this vulnerability? Well, cognitively, they start to develop thoughts and beliefs about their vulnerability. There's vulnerability. What is anxiety? It's this vulnerability to be hypersensitive to things that are fearful to you, like quitting using, or being out in society, or trying new things, or leaving the worst job you ever had because you're afraid you'll just crash. So there's cognitive behavioral and affective vulnerability. And if you grow up in an awful environment, you're going to be vulnerable to not only anxiety, but also you're going to be vulnerable to addictive behaviors that you may have seen all around you. I grew up in a disadvantaged environment where I was in the minority, and we were not, none of us had much in the way of material goodness, and I could have gotten my hands on any drug in the world probably back then. I was fortunate that neurobiologically I wasn't vulnerable to addictions. Psychosocially, I didn't go home to an abusive environment. But people who develop addictions and anxiety disorders didn't have it easy in many cases. Now, that's not true for everyone. I absolutely positively work with people who have pretty stable environments, but they go off to college and it just feels better to do a little upper before an exam. It feels good to drink a little to get sleep after you've done a little upper. And day after day, week after week, night after night, when you do that, you find yourself with an addiction. And a lot of times there is a genetic uh, component. And that's why it's important to ask if there are people in your family who have a history of anxiety. People will say, I I had a perfect childhood. And as you get to know them, you'll say, now, wait a second, you just described your mother as extremely anxious. Oh God, yeah. Everything had to be clean and spotless. And if milk ran down the side of my glass and there was a ring of milk on the table, from the bottom of the glass and I didn't clean it, she wigged out. Oh, so your mother did have an anxiety problem. Yeah, she had an anxiety problem, but that's not why I drink. Well, let's just talk about that some more. So when you're exposed to certain drugs or behaviors, whether it's pornography or gambling or crack or weed, or that's one of the challenges of the legalization movement, is there's going to be there is a lot more exposure. The red arrows, continued development and reinforcement of those behaviors is really going to be problematic because what it does is it leads to this giant complex maze of addiction that is so difficult to change. You see on the bottom that that vicious cycle I first presented, and on the top there's a developmental process. And this really 100% fully explains addiction. I mean, I'm sure of the 200 of us here, now 203, nobody will argue with this. Because if you say, well, what about genetics? It's there. What about trauma? It's at the top. What about people who, what about people who had a perfect childhood? Yeah, well, I'd love to meet them. Lucky them. Well, vulnerability can be environmental also. It doesn't mean that your parents beat you. It could mean that you were a really big sports kid and you were on every team and everyone on the team in college drank but this kind of explains everything. And why is this important? Because case conceptualization is part of your process in helping people. And wonderful, wonderful newsflash. When you take these boxes and you delete all the words in them, what you do next is you sit with your client or your patient and you go through this with them and you say, what went on in your life early on? And how did you become so vulnerable to addictions? I just heard this from a patient a week and a half ago, and it blew me away. I've known her for quite a while, and she's only recently started talking about alcohol use, and it's really problematic alcohol use. This is words from her mouth. She said, when I was a kid, I made a mental note of all the things my mother said people shouldn't do. Again, this is somebody who had a perfect childhood, right? All the things my mother said people shouldn't do. But those were the things I feared the most as a child. If I did anything like those things, I got the eyes. They were like daggers. I had to do everything perfect. That's why I'm so anxious now. And she went on, that's also why and she used the word, enjoyed drinking. It stops the critical voice in my head. And she started to cry and she said, well, use the word, this is somebody in her 30s. When mommy's not around, she said, I used to think like when she was in high school, if mommy's not around, I can drink all I want with my friends. I stop feeling shame and anxiety. Alcohol is the friend that helps me cope. So I promised case studies. I could give you hundreds of them, thousands after 40 years of practice. Here's a highly structured case conceptualization formula that I use, I encourage every clinician to use this structured approach. It happens naturally. It unfolds in a very pleasant, relaxed manner between you and this client that you're developing a good, solid relationship with. You kind of, this isn't that different from a treatment plan, but, I don't really think that a treatment plan is realistic, because in the first two visits, you learn A, B, and C about a person. And then in the fourth and fifth visit, you learn all the secrets that are really at the heart of their deepest, darkest problems. And then what happens to the treatment plan? So it's iterative. You keep building on it. So the primary problems are addictive behaviors or anxiety or whatever. You get as much as you can about the social or environmental or health or cultural context. People who are minoritized, people who are disadvantaged, people who are not in the majority, people who are stigmatized for the color of their skin or the way they dress. I was at the airport yesterday, doing everything I could to be here today, and somebody was on his knees praying. And it ain't easy being in the minority in this world. I can't imagine that he wasn't looked at by some as doing something that they would even consider doing him harm for doing. SDOH, social determinants of health, these are all important as you conceptualize people, their addictions, their anxieties, any safety concerns they have, any of their community. What happens when somebody quits using? Well, if using was part of their community norms, they got some problems ahead. The expectations are you're going to do your addictive behavior with us, and we all go out and you don't. That's pretty problematic. So again, this is your case conceptualization. You're running kind of list of things that are so important for you to help the person decide what's gonna matter. Distal antecedents, there was the top box in that last model. That's the top box, distal, in the distance. And then 4 is proximal. That's the bottom boxes. Distal is for distant, proximal is for approximate or present. Just keeping track of what the triggers are, high-risk situations. Again, those are at the bottom there. So you can use the boxes, you can use the list, but you want to know, how do people think, how do they feel, and how do they act? Cognitive, behavioral, and affective processes. You want to know how ready are they to change, but what are their goals that they're willing to change? And you want to continually integrate that. In other words, how severe is their cultural problem, the fact that they look different from others and they just don't fit in to their community without continuing the behavior, whatever. It's tying together, integration is tying together what's the primary problem, what reinforces it, what are the barriers, how did it develop, how is it maintained, what role do their thoughts, feelings, and behaviors play, and how ready are they to change. Continually integrating that so that you have treatment that makes sense. Number 10, that's what case conceptualization is all about. Okay, looking at my watch, we still got 45 minutes. I'm tempted. I welcome questions, but I'm afraid that if we take them early, we might run out of time. 2 hours, I teach these courses in full weeks, full semesters. So I boiled these slides down for 2 hours. Let me get through these, and hopefully we'll have hopefully we'll have time at the end. It is important for you to know about System 1 and System 2 thinking. And if you are familiar with it, you will agree. If you're not yet, I hope you're really intrigued by this. Us humans. Now, Daniel Kahneman, lower left-hand side, Thinking Fast and Slow. Daniel Kahneman won a Nobel Prize for this work in economics because he explained why people make stupid choices about money. So System 1 thinking is how we think to get along in life. System one thinking, it's automatic, it's fast, it's effortless, it's involuntary. It is, thankfully, the reason I can give a webinar, because I've committed all of this stuff to my, to who I am as a person, my knowledge of it, my facility for using it, etc. For some of you, adopting some of these ideas won't be in system one until you've used them over and over again. System one is how you put your pants on in the morning without looking at them, saying, what do I do with these? It's the way you brush your teeth without staring at the sink going, I know I brush my teeth here, I just don't know how. So it forms quick impressions and focuses on existing evidence. It doesn't look at like absent evidence. That's why therapy works, because you're pulling in the evidence that's usually absent from someone's mind. So you're getting people to stop thinking in system one. And again, this is Nobel Prize winning work that has not sufficiently been brought into the therapy process. And, I just knew it was time. In system one, we just looked for simple answers. You start to see brake lights on the highway going to work, and the streets of the city well. What's a simple answer? Get off the highway and take the shortcuts, where traffic's going to be lighter. Going to a party tonight, haven't quit drinking, anxious, simple answer. Have a drink before you go. Take a roadie with you in the car if you have an alcohol problem, and make sure that you, just when you get there, just have one more drink, and then you'll be very relaxed and you can kind of circulate in the group. It substitutes easy questions for difficult ones. Instead of how am I going to maintain my abstinence if over the course of my lifetime, if I keep drinking, instead it's like, how am I going to get through the day? That substitutes easy questions for difficult ones. And when system one thoughts are reinforced, they become our core deeply held beliefs. The deeply held belief, I can't quit, or I smoke because I like it. That's a core belief, but the fact is most people don't like going to the store, spending the money, $6, $7, $8 a pack, depending on where they are, for cigarettes. They don't like talking to their dealer. They can't stand their dealer. The core belief is I'd like it, but the truth is you really don't. Versus system two thinking. The purpose of counseling and therapy is to activate system two thinking. It's effortful, deliberate, intentional, reflective, slow. And again, I don't know if some of you or all of you will be at future presentations. It may be repetitive for me to do this when you come to a next presentation, but believe me, repetition, if some of this stuff is new for you, is the way things go into system two, where it's welcomed and it's hard work to remember all this and do it. And by repetition, that goes back into system one, so it becomes effortless. So I don't have too much shame in being repetitive in two different webinars. But again, the purpose is to take information that will be hopefully new to most of you, and to help you move it from, wow, this workshop was interesting and I never heard that idea, or I never saw that kind of case conceptualization worksheet, to, oh yeah, the case conceptualization worksheet. So notice I snuck in that system one and system two apply to the clinician, not just to the patient. So you're in system one when you really are masterful at what you do as a clinician, therapist, counselor, whatever you do call yourself. System two is when stuff is new and you've got to really focus and pay attention to it. And you got to search memory and say, have I heard this somewhere before? Is this what I do anyway? Is this new? Is this old wine? Oh, I shouldn't use this metaphor in an addiction presentation. Is this old wine in new bottles? What's the deal here? So, system two is smart, but it's lazy. It doesn't like to work. It is effortful. But it's important when our patients, when our clients say that they're committed to change. System two is really needed when people keep doing the same thing over and over again, expecting different results, when they chronically relapse, we got to get them to think in new ways. And for many people, unfortunately, heavy substance use, even behavioral addictions, create pathways in the brain that make it really hard to use system 2. System 1 is so embedded. So people continue to describe the barriers. Oh, I can't, my anxiety, I got to do something with my anxiety. When the people don't do the homework, when they seem disinterested or detached, when they say they can't think of anything to work on, when they tell rambling stories or miss sessions or come late or trigger your or my boredom, that's when you got to say, hold on a second, we got to dig deeper. You know, we got to get out of system 1 where there's an automatic, oh, I can't do that, or I'm anxious and the only thing I can do is drink, or I'll never get over this anxiety. System 2 is, I'll never get over this anxiety, first in system 1, and then system 2 says, you haven't gotten over it yet, but you can, and you will with the work done. So clinicians need to activate system 2, that thinking, focused, rigorous thinking. When clients say things like, well, I need to cut back. What does I need to cut back? No, you don't need to. You can actually keep using more if you want. You don't need to. It's important for you to do it if you want to recover. Or words like, I'll try. You know, you got it. This is the psychotherapy or counseling or coaching or peer. I work with peers. I work with everyone who does this work, from psychiatrists to social workers to counselors to family and marriage therapists, looking for words like, I'll try that, or I'll just cut back, or I already did that, it didn't work, or sure, or maybe I'll. All of this is kind of tentative. And these are all the dorsal fin of the shark that's biting them, that's chomping their legs off. This is subtext. It's important. I mean, the subtext beneath words like this. You're the expert. If you say so, you know, you gotta get up in the morning without a hangover for a change. No, help the person say, I need to get up without a hangover. So you, the clinician, need to activate system 2, but you got to be thinking in system 2 to get there. All right. I'm working hard to get us to the end with time for discussion because I love answering questions. And we are an hour and 23 minutes into it. I've been talking after the introduction for an hour and about 13 minutes. So I promise you, I promise you that if you use this structure, remember the components of therapy or the process involves structure, collaboration, I'm using my fingers, structure, collaboration, case conceptualization, psychoeducation, and structured techniques. I told you the most important thing, I hope I told you, if not, I'm telling you now, is case conceptualization. If you don't know the person you're helping, you won't help them. If you don't know that they feel intense anxiety, and that's why they keep using, they don't have a disordering, but they feel anxiety about change, and they feel anxiety right before they use because they fear what they'll feel if they don't use. So I always start with, what do you want to work on? I make it real. I come to you, all 200 of you, knowing that I have a job to do. I owe you 2 hours of solid work. I don't think, hey, everybody, I started out with kind of a fun question, who's looking forward to the weekend? But this isn't the time for me to joke well, it's time for me to joke, but I don't have time to joke. This is work, and so is therapy. So I always start with, what do you want to work on? And my patients are used to it. And again, this week I will see, no exaggeration, 30 people. I have 30 people. That doesn't include the 30 in the Wednesday night group. And this is just about every week. And I've been traveling all week. Everyone hears me say, what do you want to work on? And everyone knows that question means Not how do you feel? How was your week? How are you still using? How's your grandmother? How's your sprained ankle? It means I'm going to work for you. What is it we're going to work on together? And the person gets used to it and they say, I hated that at the beginning and now I get it. I would like to work on getting along better with my mother because I have to live with her because I don't have any home. I have to stop provoking police because I was back in the slammer and that's why I have to see you again. My lawyer says, I've got to see you. So I've got to stop acting the way. What do you want to work on? Number one. Then make sure you know how people feel. How's your anxiety? I know that it's really peaked, or it really peaks this time of year because the holidays are coming. And let's just get that in real quick. How are you feeling about sitting in here with me? Let's bridge from the last time we met or from the treatment you've gotten, or let's even bridge from your 12-step meeting. You said your home group was disbanded, and so you're trying a new group. Let's bridge and just tell me, how is that new group doing? Let's prioritize and discuss the items that you say you want to work on, back to the first one. And now I'm going to help you understand. I'm going to guide discovery in system 2 and say, tell me what you mean you want to work on quitting. What does that mean? The person goes, well, I don't know, work on quitting. And I say, what is the work you're thinking of? And they go, well, can you give me an example? And I say, yeah, an example would be, are you going to stop going to the store and buying cigarettes? Are you going to delete your contacts, your dealers on your phone? Is that what you mean that you want to work on your addiction? And we negotiate that. And I collaboratively agree all the time with whatever they say they want to work on. Sometimes I try to negotiate that, and sometimes it works well. I'd say 50-50. No, I need to work on this, they say. I go, okay, well, you're the boss. This is your session. But if I'm really sneaky and good at what I do, I'll go, oh, yeah, well, you didn't want to talk about your addiction, but you said you want to get along with your mother, but when you're drinking, you don't. So that's prioritize, discuss, guided discovery. I'm going to talk to you about functional analysis here in a moment. And then I'm going to talk about facilitating skill development. Ask for feedback throughout. Like I just got those nice little hands applauding. I so appreciate that. If this were a typical Zoom training that I do and I saw all the faces, I'd say, gee, I see some people who, I see a lot of us, I see a lot of blank screens. I see a lot of cameras turned off. Is there anyone with with their camera turned off willing to say what you're getting out of this after I've asked the people whose cameras are on? So while you're doing dishes or getting dressed for work, are you also able to listen? Is this stuff of sufficient interest to you? Asking for feedback throughout a session is so important because it gets your system 2 working well. And there is no help for people without homework. There's no help for people without homework. None of the models of addiction that exist out there. Again, smart recovery, cognitive behavioral therapy, brief psychodynamic therapies for addiction. I said 12 steps. Everyone's got to do the homework. You got to go outside the 1 hour where you're seeing the therapist, or the hour you go to the group, or the 7 and 7, or 90 and 90, or 30 and 30. You still got to leave and live your day, and that's what the homework is. So keeping that all in mind is really important because the anxiety isn't going to go away unless people are doing some activities to manage. And notice I swung back to anxiety. When you're doing the mood, you're going to check on the anxiety. When they say, I want to talk about my mother and my anger towards her, most anger is a result of either some kind of fear or threat, or some kind of loss that's covered up by aggressive thinking. And so you're angry at your mother. What are you afraid of when you're angry at her? I'm not afraid of anything. I'm sick of her telling me what to do. well, is it possible that you have anxiety that you're never going to get away from her and that she's going to bug you her whole life? Well, yeah, of course that bothers me. I'll say, that's what they call anxiety. And you're probably right to be a little anxious about that, because if you live under her roof forever, it can be pretty bad. So you pull in while you're in the middle of the structure, both by asking about the mood, but also as you go through other analyses. So in my year-long trainings, which this is not, these are all the techniques we can do. I'm going to teach you about functional analysis. I assume of 204 people, including me and Eric and Robert, who are our administrators I'm sure that we've all heard of motivational interviewing. That is a technique, asking open-ended questions and looking for changed thought. So stimulus management, delay and distract. Delay and distract is also known as urge surfing. Advantages, disadvantages analysis, one of my favorites. Hierarchy of values, one of my favorites. You can find most of these and worksheets and everything for free on the website smartrecovery.org. Smart Recovery. Notice I talked about a website that's free and didn't mention my book. So behavioral activation, automatic thought records, acceptance and commitment. These are all techniques that can help people to address both their anxiety and their addictive behaviors. Role playing, for example, I'm just grabbing that one. Role playing is, how are you going to talk to your mom so things don't escalate? And I'll say, let me show you what I'd say to her. You just be her at her worst. So here is, you are now getting at 9:32 my time, 10:32 your time in the morning. This is a functional or chain analysis. The first objective of this workshop was absolutely to expose you to the complex relationship between anxiety and addictions, and I've done that throughout. The second one was to talk about case conceptualization. I showed you all those boxes and all that stuff. Now, techniques. Asking people about their lapses and relapses and just use is vitally important. It's useful. It's necessary. Finding out what triggers their ultimate anxiety, depression, substance use. So the trigger, the cue, the situation, it's usually not one thing. It's usually a bunch of things. Let me just see something. And on Zoom, not just Zoom, but in PowerPoint, I can usually get a little pointer. Gentlemen, Eric, Robert, do I get a pointer? Can you see my arrow? Gentlemen?
There is a way to do it. I don't know.
Don't worry about it. Not
Okay.
a big deal. Can you see my arrow floating around?
No, we cannot.
Sad. That's all right. I know how to say upper left, upper right, etc. On the left side, you see people are pounded every day. You and I were pounded every day with challenges. If we have significant mental health problems, those challenges bear upon our automatic thoughts in system one. Oh man, that sucks. Wow, that's awesome. God, I don't know what I'm going to do. Uh-oh. Damn him, why did he cut me off? So those are potential automatic thoughts to a variety of cues that you can guess. Oh no, my coworkers are going out for a smoke and I quit this weekend. Oh no. So that's the automatic thought, the AT. The C is, what's the consequence? Consequence of, oh no, my people are going out for a smoke and I don't smoke anymore. The consequence is I feel anxious. What do I tell them? I feel disappointed. I might not be part of the in crowd anymore, the cool kids. So what's my next automatic thought? Well, I'll go out with them anyway. Now keep in mind, I'm up to the third red bubble that says AT. I automatically think, well, I'll go with them anyway. And the consequence is off I go. This is a chain analysis. And once I get there, I see that they're smoking. And the automatic thought is, oh, it's only been a weekend. I can start next weekend. I can start today. My automatic thought is I'm going to smoke a cigarette. Consequence is I'm puffing away. The automatic thought is, you know what? Since I'm smoking now, I might as well smoke this weekend. I'll try again next weekend. That's what a functional analysis is. That is a technique. That is the fifth of the 5 components. You can hear that I need a beverage because I'm losing my voice. Another technique in your new bag of tools based on this presentation can potentially be, another tool could potentially be those boxes and filling them in with people. So you start out with a blank page. And for me, when I use Zoom, I just use the whiteboard. And everyone at the library, when I'm doing the recovery group, sees what I'm writing up on the screen. And everybody out in the hybrid remote world we've had people from Portugal, we've had people always from Canada, we have people from other parts of Europe now and then come in because it's just the internet. Again, smartrecovery.org, and you just go to local meetings. And remember, I'm in Lawrence, Kansas, home of the Jayhawks, 66044. Put that in Wednesday night, and you'll see my group. The Friday night is my group also, but I have an able colleague that does that one. So I say all this because you can find these things and many more tools. But 2 tools I'm teaching you today. Use the diagram to fill things in as you sit there with your client. Use this to kind of trace what happened next, what'd you think, what happened next, what'd you think, what happened next, what'd you think. I had a guy, here's a case. I promised I'd present cases. Here's a quick case at 10:37 your time. Last Wednesday, literally, last Wednesday? I'm sorry, 2 days ago, this past Wednesday, I had a delightful, wonderful, awesome group member who's been coming to our group for 6 months say, people aren't treating me the same. I say, what did you mean? He said, these people who are my friends, he said, they're afraid to do the normal things around me. I said, what normal things? He said, like drinking and stuff. And I said, what do you do? I asked him, what do you do when it seems like they're protecting you by not drinking? And he says, nothing. And I say, well, let's do a functional analysis. You're going to go out with them. You know that it's dinner. It's not a bar. It's not a crack house. You're going out to dinner with them and your spouses, and they used to drink wine and now they don't. And you haven't said a word. Why don't we talk about what's keeping you from talking to them about it? We just do a functional analysis and come up with a lot of automatic thoughts like, I have a lot of anxiety about talking about my recovery. So if I had a pointer, I'd say on the left-hand side, the cue or the situation or the trigger for it. Now we're using the functional analysis to try to understand why the abstinent person isn't talking to his friends about the fact that he wants them to be able to be normal at dinner and drink wine if that's what they want to do. So what's your thought? And he says, well, I shouldn't impose my ideas on them. Well, what do you mean impose my ideas? Well, it's not that. It's really that I don't, I have a lot of anxiety about talking about personal things. I shouldn't talk about personal things. So what's the consequence? Well, I haven't brought it up to them. And when you haven't brought it up to them, what's the automatic thought? Well, they're still going to think they can't drink around me. And well, I start to say, what would you like to replace that thought with? And he said, you can stop there because I get it. My new automatic thought is talk to my friends. Tell them they can drink wine at dinner. I'll be okay. But it's with a functional analysis that you can do that. It's also known as concept mapping. All righty. So that's number one technique that you can use. Circles, where you put in thoughts and you put in actions and you look historically at what they've done. You look into the future, what they could do. People really like seeing things in person. An automatic thought record is where you have people keep track of the date and the time and the situation. If I learn, by the way, that most of you are the same people who are coming back to the next webinar, I'll probably cut back a lot on the first part of this and do much more of the techniques. But for today, you have your introduction to the whole thing. So the automatic thought record is really helpful. You do it in the session with the person. When did you relapse, you ask? And oh God, relapse. I relapsed Friday. It was happy hour after work. Okay, so what time was it? Time was it? I told you it was after work. I'm just curious. What time was it? Well, it was four. Well, I guess I started to think about drinking at 4:30 and we get done at work at 5. Okay, 4:30 on Friday. Situation you've told me is you're at work. Your emotions are you're starting to get a little excited, right? Yeah, it's Friday. What other emotions do you have? Well, I was a little nervous because I have quit drinking. What were the automatic thoughts? Notice I'm going through these. In a way, what you're doing is this is a diagram and this is just a table where you're filling in the details. And the 0 to 100 is how strong did you feel excited about going out that night? How anxious were you about being around people who are drinking? What do these exercises do? They force you to use system 2. They force that on you. So that you and the client, the patient, you're working hard together. You're filling out these bubbles and these tables. Here is an advantage disadvantages analysis for people with anxiety. Now you see there's italicized words in there. You start with a blank. So what are the advantages? Some people call this a cost benefits analysis. What are the advantages to continue drinking? Well, I get relief from anxiety. What else? I forget my problems. What else? I participate in life like other people that drink. What are the disadvantages? Well, if I quit my drinking, my addictive behavior of drinking, or if I quit smoking weed with my friends, I'm no longer having fun with them. And the disadvantage of engaging in my addictive behaviors is I don't have to think about my partner at home who's depressed and angry all the time. I'm with my friends. So there are disadvantages let's see. No, I think I might have described that wrong. There are disadvantages to engaging. So you compare the advantages and disadvantages, and you compare the advantages and disadvantages of stopping. Yeah, I did get that wrong. So advantages are relief, disadvantages that you're not, that your anxiety will get worse. So you get it, but you get them to fill out the advantages and disadvantages. So let me summarize, and then we can spend delightful time with you asking questions and putting questions in the chat, and I'm happy to answer them. So again, summary, 1 in 10 people in the US has an anxiety or a substance use disorder, and having one increases the likelihood of having the other. And the relationship is complex and there's no one explanation. Like medication, self-medication theory isn't enough to explain it all. Comorbidity results in much more difficult treatment because when somebody is extremely anxious and they're trying to quit, they need help with their anxiety. So it makes the treatment more complex. And it makes it more important that you help them with their anxiety. Treating both will increase effectiveness. There's good research to support that. And the treatment itself, there's no simple treatments. 12-step programs, smart recovery, psychotherapy, they're not simple. They're very complex. when somebody comes into a 12-step program, and I've gone to a lot of them now, when somebody comes in and it's new to them, their participation is so much different from how they are later. I mean, there's privacy issues, there's shame issues, and just keeping track and continually, if you're somebody who's going to go out to coffee with them after a meeting, or if you're a sponsor, if they're a sponsee, even that, it's more, it's more complex if you've ever been a sponsor. How do I know it if I haven't been one or gone, or if I'm not in recovery? I spend much of my life talking to people who share these things, explain these things, teach me these things. So people who are seeking help are way more complex than a lot of the approaches to treatment say, if you just do this, you'll be okay. It's way more complex. Remember, we operate in system one where everything's automatic and quick, and we don't have to remember which side of our head we part our hair, and we just do it automatically. You don't have to relearn how to drive your car. You don't have to relearn how to smoke a joint or get a bottle of booze. So clinicians tend to underestimate the impact of early life development and environmental processes like cultural marginalization, people who are different from the helper themselves. And clinicians tend to exaggerate their expertise and view themselves as more important to the recovery process. We are not more important than the people we help. They're the most important thing. They're the ones who are going to determine their goals and how they're going to get to where they want to be. And we, in helping people with addictions, need to think, even if you're out for coffee after an NA meeting, quick and easy answers to anyone's complex problem, for example, with anxiety and addiction. Simple answers don't work. Even as a recovery coach, I say even because you're not doing psychotherapy with recovery coaching, you're doing coaching. Thinking systematically and generating hypotheses as, for example, a recovery coach, a peer, a mentor, whatever you have, a sponsor. It's time to think in system two. Go outside the box and try to understand with the person you're trying to help. What happened to you? How did this all come to be this bad? And what are you battling besides the addiction, like anxiety? So us clinicians need to continually expand our range and not be locked into any single approach to addiction treatment, and we'll be much better off for it. We need to be flexible. We need to be curious. We need to be intentional. We need to be deliberate. These are all important, and we need to, again, understand the nature of change. Change is complex. It's not linear. It's not like each day you're going to cut back until you're not using, or today you'll stop and you'll gradually get better every day. No, it doesn't get better every day when you quit using for a lot of people. It gets worse because now you don't know how to deal with your angry family, and they don't know how to deal with you now that you're not using. It's not linear. It's important to continually formulate hypotheses, to pay attention to the context again, to identify barriers and pay attention to them, like anxiety can be a barrier. This is the last slide, I think. It's important to not exaggerate how much you can do for somebody who's in recovery. And remember that all approaches to and definitions of recovery have some value. So even if it's, no longer driving under the influence. I've given you a ton of references here, by a ton: 1, 2, 3, 4, 5, 6, 7, 8, 1, 2, 3, 4, 5, 6, 7, 15, 1, 2, 3, 4, 5, 6. These references are available to you. And Robert, I'd be shocked if you weren't sharing these slides with this good group of people somehow.
They are in the chat.
Awesome. All right, everyone. We succeeded at leaving 10 minutes for questions, etc. I would love to tell you that you look like a wonderful group of people, but I can't see you. So let's get some questions. And I intentionally moved quickly so I could figure out how the heck I was going to use 2 hours to teach a 40-hour course. Robert, will you help me out if you see any questions?
Absolutely. We do have one in the chat. I believe this was from a few moments ago. Jennifer, if you'd like to clarify, she asked, is this like the decisional balancing model?
Oh,
Jennifer,
love that.
I believe you posted that a few minutes ago, Jennifer, in reference to
Now,
the functional chain analysis.
decisional balance should be in here as a technique. Decisional balance is helping people see. Oh, here's decisional balance right there. That is the decisional balance. What are the advantages and disadvantages? What are the benefits and costs? Decision. I hope that answers the question. That's what the advantages, disadvantages analysis does. You can see my hands. Decisional balance is what is the left side, what is the right side saying, and are the advantages of stopping heavy enough to overcome the disadvantages of stopping? I hope I've answered that question. Robert, I'm ready for the next thing. Somebody said, I love this training. Thank you. You're so welcome. And email the slides. That's Robert's job. Thank you for your nice comments. Yes, that was a reference to the advantage, disadvantages. Good, great. Hey, I'm looking at these, Robert. I'm good. Thank you for a fresh conceptual model. Don't want to miss follow training. Oh, thank you about the books. Thank you, Bruce. Thank you. Oh, you're all so sweet. Same structure. Oh, groups. If Robert has me back to do groups, I also have a book on groups that's old. Oh, but again, you asked, I'm going to tell you. One of my favorite chapters in the book is on groups because I love running groups. That's why I do the Wednesday night groups. Here's the structure for groups. You ready, everyone? You go in and you have check-in, and check-in is what is your name? What is the addiction you're working on? What is the status? What are your goals and what is your context? And then the people who go early on, again, I'm going to say that again. The structure is even with 30 people, check in by saying your name, your addiction, the status, you go, oh, here, look at this, watch this. Name, addiction, status, goals, context, and then topics for discussion. There you go. So each person checks in with name, addiction, status, goals, and context. And then early on, someone will say, that's what happened with the guy the other day. He said, my friends treat me differently. And the whole 90-minute group, the entire 90-minute group was about how do you deal with the new you? How do you explain who you are to people who don't know you as a person not using? How do you balance clients that live on locations where weed is medical, but they still, oh my goodness. Thank you, Karina. Oh my God. The whole idea of medical marijuana is overwhelming because I've been told so many times in serious ways, in joking ways, in sarcastic ways, in absurd ways, and in very serious ways, in very legitimate ways. I couldn't survive without my cannabis. I couldn't survive without my gummies. I wouldn't sleep. And I don't know what to do about it. We do not have prescriptions for medical marijuana anywhere in the world. And so how the heck could we ever know what's really medically indicated? It's very difficult. And you just have to, you know what you do? Here we go. Let me get back to my slides. What you do when somebody says they're using medical marijuana is you say, how important is it to you? Number one, salience. To what extent do you use it for all of your moods and all the time? How much do you need to use to get the effect? If somebody says, oh, it's medical marijuana, I only use it if I feel a panic attack coming on. How often is that? Oh God, once a month. That's good use of medical marijuana, right? Once a month, only before a panic attack. But if the tolerance is they need more and more, not once a month, and you say, you're here talking about it, do you have some inner conflict about using it, some guilt maybe, or some fear that you do have an addiction? What do other people think? And when you try to quit, do you relapse? So thank you about the medical marijuana. How do you balance clients living location weeds? I really appreciate the nice comments. That's why I love to teach, is because I love to work with people who love to learn. Change someone's mandated to, I get mandated patients all the time. See, the reason why I focus on, I'm go back to the slide. The reason why I focus on the process right there. Robert, are you seeing the slides I'm jumping to?
I am.
Good. You see the bottom, how change is facilitated. If you are seeing me because the judge said you have to, and I act in ways like some kind of, authority figure who's the boss, and you better change it, it's game over. And so I've worked with thousands, again, 40 years times, let's just conservatively say 20 hours a year. That's 100 hours a week, 100 hours, whatever it is. I've seen tens of thousands of patients, and so many of them are there against their will. And, they figure out quickly that you're not there to control them. You're there to understand them, conceptualize them, empathize with them, etc. Make sure if there's a future topic webinar, think of what you would see in another training. Oh, that's amazing. Yeah, group therapy is what I'm really thrilled about. Addiction, cocaine, process. No, cocaine, again, another workshop I do is on the addiction syndrome, which is a way of understanding all addictions as having common underlying causes, course, consequences. The treatments tend to be all the same, etc. All righty. My watch says, we got a couple more seconds. My watch says 9:58, which means your watch says 10:58. What else? Yeah, I think role playing might have taken up more time than we had, and I think we'll stick to this process. Can I keep this chat so when I'm down in the dumps I can read it and then I'll be happy? Save this chat from me. It'll bring me joy in the future. Thank you for being extremely nice people and kind and generous in your compliments. And I think, Robert, you want to say a few words, so I'll give you that last minute. Thank you all. Robert, it's yours.
Awesome. Yes, thank you so much. Thank you so much, Dr. Liese. All the comments in the chat are obviously very positive, and we're very appreciative of the time that you took and put into today's webinar. Thank you so much, everyone. Quick couple business items before we conclude. We have included Dr. Liese's contact information on this slide. So please note that if you have any additional questions, you can send him an email. Once we close the webinar here in a few moments, you will get redirected on your browser to the evaluation. So please don't close out of your browser once we end this webinar. Make sure you redirect to that evaluation. Go ahead and take that. Once you access the evaluation, you'll be prompted to sign in or register to complete it. You can register as a visitor at no cost if this is your first webinar with us. You may do so by clicking Haven't Registered Yet. You must use the same email address you used when you registered for today's webinar and when you set up your profile in FADA system. This is the only way to connect your attendance and your profile. After you register or sign in, you will be directed onward to the evaluation. You'll get an email later today that also includes the link to the evaluation. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the professional information section of your profile. Please note that the evaluation will close at the end of the day on Wednesday, November 22nd, 2023. And I do see lots of positive comments in the chat, as well as some other topic suggestions. Please make sure in that evaluation you list those so we can share those with Dr. Liese. If you experience difficulty logging into your account or accessing the survey, you may contact our team either by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org before November 22nd, 2023. Please note that we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. As a reminder, the recording and materials used in today's presentation will be available on our website within 30 business days. To access the recording and PowerPoint, please visit www.fada.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. I'd like to again thank you, Dr. Liese, for your time and your information. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Everyone have a great day. Enjoy your weekend. On behalf of us here at FADA and Dr. Liese, have a happy Thanksgiving, and please hold for the evaluation.